So breast cancer is a disease that's very common, and we have a population that are growing older, and those two things are combining to create larger and larger number of older women with breast cancer. Many of those women remain very fit, and in those situations one would treat them just as you would a younger woman with the same disease. But also many older women have other medical problems, comorbidities and physical frailties, which might make going through standard treatment paradigms more difficult for them. So the discussions we had today in a MDT session at SIOG were how do we best evaluate and deliver the most appropriate care for the older patient who might be physically frail. Our panel consisted of surgeons, medical oncologists, clinical oncologists, and we had contributions from nursing and patient members of the audience. What's very clear is that any cancer treatment of an older patient needs to be prefaced by a proper assessment of their fitness and frailty. And there's been a lot of discussion at these meetings about what is the best way to do that, what frailty and assessment tools could be used most usefully and most readily in our clinics that we can start making some assessments. Alongside that, we've been talking about tools that help us assess the prognosis of the patient's disease and the benefits of our treatment, and also tools that allow us to understand what the patient's survival might be if they didn't have cancer, because all of those data go into the decision-making process. So over the 19 years of SIOG meetings, there have been a lot of focus on the appropriate ways to triage, assess patients, older patients for cancer treatment. And there are a large number of tools available, and we've heard about many of them in this conference. I think the big challenge for the community now is to see those tools rolled out into everyday practice. So the practice of geriatric oncology is not specifically geriatric oncology. A phrase that's often heard at this meeting is that all of us are geriatric oncologists. This is not a specialty of its own. All of us who practice adult oncology are in the practice of geriatric oncology, so we should be adopting these processes. From my personal point of view, the assessment tools that a centre or clinical academic unit, teaching hospital, community oncology department should be using is the tool that best suits their practice. And it may be that the suite of tools that they wish to use are different to another centre. But the important thing is that they start making these assessments, understanding them, sharing them, and talking the same language with their colleagues in their department, with their geriatricians, their general physician colleagues, surgeons and other oncologists. An expression I like a lot is that we shouldn't let perfection be the enemy of good. These are tools that we need to start using and use the tool that you are most comfortable with. Well, we practice oncology in a multidisciplinary setting, and the best treatment of breast cancer involves all paradigms of modern cancer therapy. A woman treated with breast cancer may need treatment with hormone therapy, chemotherapy, modern biological therapies like trastuzumab, and surgery. So all of those opinions are necessary in the room to deliver the optimal combination. And sometimes in sequence therapies for our older patients, we have a problem of resilience, that a patient may be fit for the first treatment in a sequence, but may not have the resilience to then go through the second or third adjuvant therapy. So a team coming together and deciding what is the patient fit for in a totality of a treatment regime is also really important. So in the area of treating breast cancer in older people, one of the main advances is understanding treatment de-intensifications. A lot of our oncology research is about giving more treatments to patients. A lot of the most productive research in geriatric oncology for older breast cancer patients is what can we safely do less of. So we now have useful data in the de-intensification of duration of trastuzumab therapy. We have data on using single-agent taxane therapy with trastuzumab in the HER2 positive patient. And in radiotherapy, we have data on hypofractionation, giving much shorter fractionations of radiotherapy. So in the case of the UK Fast Forward study, 28.5 gray in 5 fractions in 5 days, as opposed to a 15 or 25 fraction course of radiotherapy, which may be difficult or off-putting for an older patient. So these trends to do less, to remove and reduce treatment burden, but still get equivalent treatment outcomes is an important research direction in the older person with breast cancer. one of the things that came out in the MDT discussion this morning was the cases we discussed. One of the patients in the clinical history that's provided had some mild cognitive impairment. Now, I think mild cognitive impairment is a major challenge to the treating team. Questions from the floor related: how could we properly consent a patient with cognitive impairment in an ethical and appropriate way? And both people from the floor and on the MDT took that challenge. Proper assessment of cognitive function with screening tools, dementia assessments is important. The involvement of family and friends, and the ability for a patient to return more than once to check their understanding and comprehension of the treatment plan outlined to make sure that consent is appropriate are all important. I think the other important thing about cognitive impairment was for oncology teams to understand what a significant difference that might make to the patient's overall mortality without cancer and to factor that into their decision making.